Okay, well, it's a pleasure to be here. I want to thank Bill Carlson and the Planning Committee for inviting me to speak at this meeting. It's just a beautiful agenda for this meeting for the next couple of days, and I'm very excited to be part of it. Thanks to Dawn for facilitating our panel this afternoon. So I have been asked to talk about a process that we had the opportunity to engage in developing and evaluating a novel digital therapeutic for the treatment of substance use disorders. So I'm going to tell you a bit about the background to development of this and some of the clinical trials research that we conducted evaluating this. And as you heard from Dawn, we were very excited that this line of research led to what was the first FDA authorization of a prescription digital therapeutic. So in addition to my academic affiliation at Dartmouth College, I have a few affiliations with several small businesses. They're listed here, the third of which, Therapeutics, is the organization that sought and successfully obtained the FDA authorization. And I surely want to acknowledge the research funding for the work I'll present today. This work was funded by the National Institute on Drug Abuse at the NIH, and including our center grant funding, which is a center grant from the National Institute on Drug Abuse. So the theme of this meeting is on digital health and computational health and science in the space of health and medicine. And as we've been discussing, as was so beautifully described in the keynote this afternoon by Sandy Pentland, digital technologies have just transformed our world in so many aspects of our society, and retail and finance and business and travel, and how we take classes and how we have social interactions. And the work that we've been heavily engaged in is the application of digital technologies in the health space to not only accelerate what we can do within healthcare systems, but to have lots of opportunities for new insights into health behavior and therapeutic tools targeting health behavior, even outside of healthcare systems. And so our work has been heavily focused on leveraging advances in digital technology to both glean new insights into individual health behavior and within individual variability and clinical trajectories within an individual, as well as at population levels. But also, we've had a very strong priority focus on the development and evaluation of digital therapeutics, so these software tools that can help in the treatment of various disease indications. And a great deal of our work has been in the space of substance use disorders. So we've been very excited about the data, really, that underscore the promise of digital technology in the treatment of multiple areas of health behavior, including substance use disorders, and including the promise of these tools to extend the reach and the impact of clinicians. So these can be, some people call it clinician extenders, therapeutic tools that sort of can supercharge your workforce and extend the reach and the impact of that healthcare workforce outside of a healthcare setting 24/7 as people move through their daily lives. And so this is sort of like a therapist in your pocket, right? Like a clinician in your pocket that can be with you and accessible on demand, that can help individuals achieve personal goals and manage health conditions using evidence-based tools. So I think about this as anytime, anywhere healthcare, right? So this is around how do we leverage the ubiquity of these tools to provide resources anytime and anywhere. And as we heard from Sandy's talk, all over the world, virtually any population you can think of has access, or either has or is getting access to these types of technologies, even communities that have other limited types of resources in some low and middle income countries. And so there's tremendous opportunity to harness these tools. Just briefly, I wanted to mention our center. This is the only center of excellence that the National Institute on Drug Abuse funds, specifically focused on technology treatments for substance use disorders. So it's a very broad interdisciplinary team at Dartmouth College and spanning national and international partners focused on using science to inform the development, the systematic evaluation, as well as methods of sustainable implementation of digital therapeutic tools for substance use disorders and related issues. We're involved in a whole array of issues from mobile sensing to digital phenotyping to development testing of digital therapeutics in all kinds of levels of evaluation and implementation and sustainability. And we have lots of resources for folks who may be interested in this space that we would love to share with you if you're interested in this. Okay, so my charge today is to talk about a digital therapeutic that we first developed the first iteration of probably in the 90s, in the late 1990s. And this is specifically targeting substance use disorders. And it's basically an intensive behavior therapy approach that has been shown to be highly effective. So at the time, it was delivered by highly trained clinicians in one-on-one interactive counseling sessions with people struggling with addiction, and was viewed as one of sort of the gold standard models of addiction care. It was called the community reinforcement approach to behavior therapy. And in the first iteration of this in the 90s, we developed an interactive web-based version of this therapeutic model. And really the first goal here was to extend the reach of access of this evidence-based gold standard approach to behavior therapy. The data were very compelling from research trials underscoring the utility of this approach, but it wasn't what most people used or had access to. And there were lots of challenges in delivering this with fidelity in lots of systems of care. So at the time, we developed a web-based version of this that was really intending to take the active ingredients of that therapeutic model and deliver it via interactive technologies on a web-based platform so that we could promote widespread dissemination of access to this tool. So this is a pretty intensive behavioral therapeutic intervention. It's not just on enhancing motivation for change. It's really teaching skills and giving people new resources to help in making changes in self-defeating patterns of drug-taking behavior. So it has about 60-some sections in it that are focused on helping people understand their behavior patterns and understand their risk patterns and sort of consequences of substance use, and understand and learn new strategies to disrupt these harmful sort of behavior chains, to leverage personal and social and vocational and other types of resources to help in initiation and maintenance of change around this, to learn new skills like stress management and coping skills and time management and communication skills that can help people in lifestyle restructuring that's related to substance use and work toward achieving personal goals. And there's a whole behavioral economics component of this that leverages motivational incentives to help people who want to make changes in their problematic drug use in actually initiating and sustaining those changes. So it's a multi-component model grounded entirely in this evidence-based therapeutic approach. And it's all interactive and self-directed. So it's all done one-on-one by an individual interacting with the software. These are just some screenshots from the initial version of the tool that was used in some of our research projects. Again, there are 60-some sections, but there's lots of different topics addressed in this, including helping people to learn about behavior change, problem-solving, therapy, making decisions about activities, and peer groups, and other topics. So I'd be happy to tell you more about the intervention, but what I'd like to do now is shift to telling you a bit about some of the studies and the patterns of findings we saw in some rigorous experimental research evaluating this tool in different kinds of implementation models. So the first one, let's see if I have a pointer here. I have a pointer? No. The first trial was a study conducted with individuals, adults struggling with opioid use disorder. As we know, this is the leading cause of death right now among Americans under age 50 in our country is opioid overdose. It's a very significant national crisis. This particular study was conducted with that population of folks meeting criteria for opioid use disorder. And when those individuals came into this study, they all received medication, a medication called Suboxone, which has been shown to be very effective in stabilizing the brain neurochemistry of people struggling with opioid addiction. But what varied in terms of what people were randomized to in this 3-arm randomized controlled trial is the type of treatment they received on top of the pharmacotherapy. So I'm just going to give you snapshots across these slides of patterns we've seen. If you'd like any of these papers, we have lots and lots of data from all these studies. So in this particular study, the folks who were reflected here in the middle bar, which is the blue bar, these were individuals who were randomly assigned to a therapist who delivered the evidence-based gold standard community reinforcement approach to behavior therapy. Okay, so they're doing this in one-on-one sessions 3 times a week, this very intensive, evidence-based intervention. We had lots of fidelity checks in place to ensure that it was being delivered in the way that had been shown to be most impactful. The group that's reflected in the red bar also had a therapist, but they only saw their therapist 1 out of every 6 sessions. And the 5 out of 6 sessions, they didn't meet with a therapist. They instead, in this study, went to a computer lab at the addiction treatment site and interacted one-on-one in an interactive way with the computerized version of this therapeutic model. And then the group in the gray bar received what's considered standard treatment in many of our outpatient addiction treatment systems in the United States, which is not reflective. There's a lot of variability in what's done there, but it's not reflective of this community reinforcement approach to behavior therapy. So what we have seen in many results from this trial, and this is one example of those, is that even when we offload the majority of the therapeutic intervention to a digital platform, we get comparable outcomes in terms of abstinence from opioids and cocaine to outcomes achieved by exclusively clinician-delivered care, delivering evidence-based treatment, both of which are better than what most of our addiction treatment systems provide in the US. This was measured by objective urinalysis testing for these substances. So now I'm going to tell you about a different therapeutic clinical design, which was, again, an outpatient study, and this was with, again, individuals with opioid use disorder entering outpatient treatment. Everyone received medication. But this was a 2-arm study. So either folks received treatment as usual, which is in the yellow bar here, which included some counseling contact as well as medication, daily medication for opioid addiction. Or they were assigned to a model of care where their clinician-patient contact time was cut in half, and they still spent half their time with the clinician, but the other half of the time was spent in this using this interactive digital therapeutic. So let's say instead of meeting 60 minutes with the clinician, they'd meet 30 minutes with them and then spend 30 minutes interacting with this digital tool. So the results showed that when we cut in half patient-clinician contact time and replace it with this evidence-based model delivered entirely on a digital platform, we had significantly better treatment outcomes, including, as you see here, significantly greater weeks of opioid abstinence for the group that received the tool as part of the care model versus those who didn't. Okay, and now I'm going to give you a different kind of design. So I've shown you designs where we're sort of partially replacing clinician-delivered care. This is a different design, which is just adding a tool as a supplement to what people are doing already. So we're just adding this as an adjunct to medication-assisted treatment for opioid use disorder. So now this is a mobile version of the tool in this particular study that people could use when they entered treatment and could have it as they move through their lives. And what we looked at here is that when people entered outpatient treatment and got this tool as part of the care model, how did it affect treatment retention for the first 3 months of their treatment episode? And what we saw is that we retained a significantly greater percentage of people in treatment if they got this simple tool as part of the care model versus if they did not. And the same pattern emerged when we looked at opioid taking behavior. So that pattern also translated into urine toxicology data showing that we had greater abstinence for the target drug of opioids, which was the problematic drug people were presenting with treatment for, if you got the tool as part of the care model versus if you didn't. And so this is just very compelling in that, offering this tool as an additional tool in the therapeutic model can have these kinds of added values that translate into clinically meaningful outcomes for patients. So the next trial, and I'll walk you through this data slide, but this next trial was a study conducted on the National Drug Abuse Treatment Clinical Trials Network platform. This is a national research infrastructure spanning the US where you can run the same protocol multi-site concurrently. So you can tap into lots of different diversity in your samples and geographic setting of your study locations. So the Clinical Trials Network, the CTN, conducted a multi-site trial with this therapeutic tool, which again we were calling the Therapeutic Education System. And it was a really diverse array of people with substance use disorders involved in this trial, very diverse. They called it sort of the all-comers studies. So people with stimulant issues and cannabis and alcohol and all kinds of mixed drug use were eligible to participate in this study. And so these were all folks in outpatient addiction treatment programs. And so in this trial, for sake of time, and I'm not going to show you all the patterns, but there was an advantage in the main analyses showing the value of adding this therapeutic tool as part of treatment in these systems. But one of the really interesting results from this trial is reflected here, and that is that we saw a particular advantage for using this tool among people who were continuing to use at the time the trial started. So sometimes when you start these clinical trials, by the time people engage in the trial, their first urine sample might be negative for their target drug. So it's important to sort of pull that group apart from people who are still actively using. So unfortunately, I don't have a pointer here, but if you look at the top two lines here, let's see if I can do it on the screen. If you look at the top two lines here, it's not reflected. This is the pointer? Okay, great, thank you. So these are the folks that are coming in at the top here that already have, are already giving urine samples that are negative, right? And what we find is that when you add this therapeutic digital tool on top of, to folks in that condition, there is a slight advantage. This is the top line here. A slight advantage in terms of their drug use behavior relative to those who don't get the tool. But the bigger, more robust effect that we found was for people who were active users at the time of entering the study. So for that subgroup, when they received this digital therapeutic tool on top of the care model, we had much greater increases in abstinence from their problematic drugs compared to this group here that were active users when they entered the study but did not receive this tool as part of the care model. And just one more result from that study, this is just looking at treatment retention. Treatment retention is a very important predictor of longer-term outcomes for people engaged in substance use disorder care. And we saw an advantage to keep people in treatment longer when you had this tool as part of the care model. So these data, actually, from this last clinical trial, are the data that the Food and Drug Administration reviewed for safety and efficacy data to look at the potential authorization of this tool as a prescription digital therapeutic. And so in September 2017, Therapeutics had pursued and really pioneered this space because this didn't exist as a category yet of review and authorization from the FDA. But this category of digital therapeutic was created, and this tool, now called Reset, is the first FDA authorized tool. And it's really based on those data because one of the beautiful things about the NIDA Clinical Trials Network is those studies are just incredibly rigorous. They're run kind of like a pharma company would run a medications trial, and they have, very extensive oversight and sort of, there's an independent quality monitoring group, there's an independent data and statistics coordinating center, there's all kinds of centralized aggregate data collection and lots of oversight. So that trial produced the data that informed this authorization. And so, I know this is the topic of this panel. This is a really exciting new space because now we have the ability for providers to prescribe software to treat a disease indication. And so this is an example of that and happens to be the first of software to treat substance use disorder. But this is a brand new space, and this is undoubtedly a part of the future of medicine. And one of the benefits, I think, of this model is that for people who are interested in navigating the space of what apps are out there for alcohol or depression or managing sleep or whatever your issue is, it's really hard to navigate that landscape and know what are the best, most evidence-based tools that are out there. And so by having tools that can go through this kind of rigorous test evaluation and vetting process, we can start to identify those tools that really rise to the top in terms of the ones that have the strongest empirical support behind them. So I will stop there. Thank you so much.